Okay, hello everyone. My name is Hamid Ektiari, University of Minnesota. I put my slides in the QR code. So if you scan the QR code, you will have access to the slides. So the question is, we have been discussing today about different neuromodulation technologies. We have been discussing about TMS, we have been discussing about the neurocircuits, using DBS to be able to target them. But the question is, how can we actually use neuromodulation in daily clinical practice of addiction medicine? Is it the prime time for it? And can we use the neuromodulation technologies in our daily clinical practice after this conference? Starting to think, okay, we do not have in our clinical practice, let's just plan to have that in our daily clinical practice. So there are different brain stimulation technologies. How many of you in this room have touched any of these technologies that I'm showing above? Have you ever touched any of those technologies? Okay, good. So there are people who have access or have some personal experience with some of those technologies. Of course, we use ECT in daily clinical practice in psychiatry, most of the sites. But what about the other technologies? And how we might be able to use them in the actual clinical practice? And is this a prime time for it or not? So that's the main question I'm trying to address and the challenges that we are facing for that. So there are different brain stimulation technologies. As an example, electrical stimulation, magnetic stimulation, and there is a significant growth in these technologies. How these technologies are kind of evolving over the time, and there are many new studies in this field. But specifically for the field of addiction medicine, I think that we have 7 challenges to use these technologies in the actual clinical practice. And I'm going to address those challenges and conclude at the end whether it's a prime time to use it in the clinical practice or not. So that is the main thing I'm trying to address. Does it make sense? Sounds like a good plan for the end of the panel to be able to conclude and plan for the future. So these are the 7 challenges that I'm going to discuss about what is going to be the best target, how to individualize the targets, are these targets reliable, how to optimize the targets based on the stage of the disease, whether they are in their first few years of their addiction, they are in something like their 20 years of addiction based on the stage of their addiction, how to optimize the dose, how we can optimize the state or the context of the stimulation, and management of comorbidities. So these are the 7 challenges I'm trying to address in a very short amount of time that I have today. No conflict of interest. My lab in University of Minnesota is mainly kind of focused on developing brain stimulation technologies for addiction medicine. I'm trained to be a neuroscientist and psychiatrist, so I try to combine the actual clinical practice and doing the stimulation in a sort of daily practice. I work as a part of what we call medical discovery team on addiction, and this is a collaborative group of people that we have that we work together. Mark Thomas, who is the head of the team, is here. So we try to see how we can do things together, and there are definitely potentials for collaboration with other teams around the world. So we are definitely kind of welcoming any sort of potential collaboration in the future. Specifically using TMS as one of the most frequently used technologies right now in the field of neuromodulation. What are the applications for TMS that they have already received FDA approval? So we can use them in the actual clinical practice based on the FDA approval that we have. We have that for depression. What else? Bipolar. What else? OCD. What else? Tobacco. What else? Okay. So MDD 2008, OCD 2018, anxious depression 2021, a specific protocol, we call it accelerated protocol for individualized fMRI-based TMS. It's called SAND protocol 2022 for depression. And now age expansion for TMS from age 15 to 86. So these are the current approvals that we have. And also one specific approval on the smoking cessation in August 2020. And that specific approval is for a specific coil that mainly target an area that we call frontopolar cortex. okay? What do we have in Europe in terms of the C approvals that we have in Europe? And you know the standards for C approval compared to FDA approval is totally different. They have a sort of lower threshold to accept something for C approval. Specifically for C approval, there is a approval for using TMS for what they call psychoactive substance use disorder. And psychoactive means every substance use disorder, right? So substance use disorder in general, based on the studies that have been done mainly on cocaine use disorder and on left DLPFC. So far, left DLPFC and frontopolar cortex, they already have FDA approval or C approval, or there is a level of evidence for them. So discussing about the targeting biomarker, what is the right place to target? In depression, there is a reasonable level of evidence that potentially the network between dorsolateral prefrontal cortex and subgenual cingulate cortex, this interaction is one of the best targets to be used for clinical use in depression. And there are even companies that they patented specific ways of measuring that biomarker in the US, and there are few other companies that are working on that. So for depression, things are reasonably clear, and people have been working in the field of depression from at least 2008, so there is a huge amount of data that we have in the field of depression. But this is not the case for addiction. So the level of data that we have in addiction is very limited. But people are considering this specific circuit. So today, we have been discussing about this specific circuit, or number of circuits that are important in the field. One is the executive control network, the green one, and then the other one is DMN, or default mode network. And it seems that when people are in the state of craving, the DMN is more activated. DMN and subcortical areas, not like nucleus accumbens, areas that are related to craving. And then when people go to the state that they have a level of control, they have an activation on executive control network. So it seems that when we optimize the balance between these two circuits, we can optimize the level of control and craving that people have. And addressing and targeting nodes of these networks, as an example, DLPFC as a node, or ventromedial prefrontal cortex or frontopolar cortex as a part of DMN network. When we target these nodes of these networks, we can modulate the balance between these two sides of these two networks and optimize the craving, okay? So we put together all the protocols that people targeted these circuits, and the question was, do we have enough evidence that these stimulations, they can actually change the level of craving that people experience? The slide is very busy, but just to give you, these are all the protocols that people use in different studies, okay? The ones that they have green lines, there is enough study, multiple studies that show that there is significant results. And as you can see here, the first line is left DLPFC with high frequency TMS. The one with deep TMS is the one that we have been discussing about frontopolar cortex. And then the other one in a TES, or electrical stimulation, and it is mainly when you put the electrodes on left and right DLPFC and actually put the amount of electricity here. Because when you put the electrodes on the left and right with electrical stimulation, the majority of electricity would go here. So it seems that that sort of model that I'm discussing about today, what we call it dual target, it seems that these two major targets, frontopolar part and the LPFC, these two targets, based on their connection to the subcortical areas, are the main targets in the field. Does it make sense? Okay, so we have a reasonable level of evidence that these two targets, they are working, and it seems that these two targets are working because of their connections to subcortical areas that are driving craving and urge, okay? And these two main subcortical areas are nucleus accumbens and amygdala, okay? So that is a circuit that we have that we target in the field. So we try to see how we can individualize specifically targeting for each individual and see is there any inter-individual variation in terms of how to optimally target these areas. One of these areas is the frontopolar cortex with its connection to amygdala, okay? In a study with Ghazali, one of my postdocs in my lab, we explored that in a group of methamphetamine users, 60 methamphetamine users, and we explored whether the connectivity between amygdala and frontopolar cortex and the best target for each individual within their space, within the frontopolar space, would be different across different individuals. The dots that you see there, the red, yellow, the red, yellow, and the orange ones, the range that you see there are each of them one single meth user, patient with meth use disorder. And as you can see here, this is the X, Y, and Z axis, and these are millimeter. These are the numbers and the distribution of these areas. So it's pretty widely distributed across different areas of frontopolar cortex. And we showed that when we specifically consider these individualized connectivities to amygdala, the level of craving would be correlated to these individualized connectivities, okay? So this is the distribution of these areas around FP1 and FP2 in frontopolar cortex. As you can see here, it makes sense to have individualized targeting. Even we showed that the way that when you put the TMS coils over these areas, the orientation of the coil would matter in terms of how you can optimally engage these areas. And now we are trying to even use robots to be able to exactly target the right area for each individual patient and see how we can optimally do that. We have recently published that addiction biology, the entire pipeline is already available there. So if you are interested, you can just look into that specific paper and we discuss and provided the details. But that is the idea in terms of for each individual patient, we can find the best target and optimally do the targeting. It can potentially improve the results, but I can tell you that even the group level targeting without that level of precision could potentially work. So optimization could add a little bit of further better results, but most of the stimulation methodologies that we are using, they are not that much precise. So it is still reasonable to consider even kind of not doing the individualization, while the individualization could potentially improve the results. But not only DLPFC and frontopolar, so there are other targets that we are thinking about in terms of the parietal cortex and other parts of that's the same network, and we are trying to optimally do that. But one of the challenges that people are asking, they ask, okay, if you find that a specific target in one area, and the patient comes back in few days afterwards, if you do the same, can you find the target to be exactly in the same area, or the target could be moving in different places? So are you discussing about the one single target, or is it a moving target? So we need to show that these targets are reasonably reliable. And this is another kind of a stage of work that we do. We do brain imaging, and then after some 2 weeks, we do brain imaging again. And we showed that from baseline data to replication samples that we do, there is a reasonable level of replication, and some brain activation, some of the targets could not be there in the quality that we had before, but many of them would stay in the same place in the group level. And even in the individual level, when we do baseline assessment and then we do replication, when we put them together, there are still some variation, but there is a reasonable level of consistency in terms of the target would still stay at the same area, so you can target them. Another challenge that we are facing in this area is, okay, how to do this level of optimization. So we have been discussing so far about how to optimally define the target, right? But target is not the only factor that you need to consider in defining the protocol. We have a new paper that we discuss about 4 dimensions of individualization or optimization. One dimension is target, right? The second dimension is about dose, how to optimize the dose of the stimulation. From the field of depression, so I do TMS for depression in a daily clinical practice, okay? And I can tell you, TMS for depression works. And I'm happy to do that for my family. I'm happy to do that for my kind of kids. So it is something that I have done TMS multiple times on my own brain. So I can tell you, whenever I run a trial and I want to do a stimulation, the first one who receives the stimulation is me. So I want to make sure that whatever I'm going to provide for my own patients, I'm happy to do that. Probably not for DBS, but for TMS, at least I'm happy to do that. Yeah, that seems a little bit scary for DBS. But at least for TMS, I feel it is reasonably safe that I'm happy to do it on my own brain. And I've done that on my own brain several times. And there are brain stimulation technologies I'm still not very happy to do it on my own brain. But TMS seems very reasonable. So from many studies in the field of TMS and my own clinical practice, you see that some of the patients, they respond in the first few days of the stimulation. But there are many patients that they need at least 20 to 30 sessions of stimulation to actually make benefit from the stimulation, okay? And there is a very nice study that they showed that the initial results in 7,000 patients with MDD, they showed that the initial result starts with 10 weeks of stimulation, but without 30 sessions of stimulation, you will not get to a level of sort of plateau for having a reasonable level of results. So it seems that we need to have enough dose to have response. And interestingly, in the field of TMS, there is no level of TMS that you will have a sort of toxicity. So there is no evidence that any level of TMS could give a level of toxicity to your brain, at least so far. And it seems that the higher level of dose that you can provide, potentially you will have a better results. Most of the addiction studies so far, I think, they are underdosed. And we definitely need to optimize the dosing. Dosing is definitely going to be a very important factor. The third factor is what we call a state dependency. And it is very, very important factor. When you are in different states, your brain connectivity is very different. As an example, if you do TMS for people who have depression, if they sleep under TMS, it doesn't work at all. Why? Because that specific connectivity between DLPFC and subgenual cingulate cortex that we are targeting is not connected anymore when people are asleep. So the state that people have, because in a state A versus a state B, there are different connectivities. And when you are doing the stimulation, connectivity matters. And multiple studies, they show that you need to have people to a level of craving. You need to induce craving. You need to have them on the state of craving to have the intervention works. Because when they are in the state of craving, then those connectivities are actually there in the place. So you need to put people on that level to be able to have access to those subcortical areas. So the state is important. And many of even the protocol that received FDA approval for smoking cessation, it has a component inside that you need to expose them to smoking-related cues to activate their craving to be able to make an impact. Even for the OCD protocol, that's the part of the protocol. You need to expose them to OCD-related and make the anxiety go high and then do the TMS. And then you will have the impact. So a state is definitely important. The other factor that is very important is the timing and the temporal aspect of intervention. One kind of recent analysis that we are working on right now, we have, as I told you, we have the connectivities between subcortical areas like nucleus accumbens, inventory striatum, and frontopolar cortex and DLPFC. Interestingly, we show that these connectivities changes over the time from the people who are in their early addiction to those who are in their later time of addiction. How? Let me show you this, the next figure. So those who are in their, let's say, their first 7 years of addiction, compared to those who are from the 7 to 14 years of addiction, compared to those who are in the over 14 years of using substances, the level of connectivity between these areas are different. So frontopolar cortex in connection with subcortical areas is mainly involved in the first few years of addiction. They have more impulsivity, they have more passion to use substances. But over the time, when you evolve in the process of addiction, you get to a level that is mainly DLPFC running the show. And then the people are just thinking about, okay, how can I find the drug? How can I kind of find a kind of a good place to use the drug? It's just mainly an executive task, not very much an emotional process. And then even there are ideas potentially, when we are discussing about frontopolar and DLPFC, those who are in the early phases of addiction, potentially frontopolar cortex could be a better target. For those who are in the later stage of the addiction, potentially DLPFC could be better. So even these factors are going to be important in terms of how to optimally do the stimulation. And the last point that one of the two last points I need to address today is the issue of comorbidities. We know that we already have FDA approval for doing TMS in depression, anxiety comorbid with depression, and OCD. How many patients that you see in your daily clinical practice in addiction medicine that they have depression? Many of them, right? So many of them that you see, and many of them are actually treatment-resistant depression. So you have done multiple different treatments for them, provided different medication, they have not been responding. They are actually eligible to receive TMS and neuromodulation because of their comorbidities. And interestingly, most of the studies so far that they have done things for TMS and other things, they actually excluded people with substance use disorder. But few pieces of evidence that we have, TMS works in people with substance use disorder and have those who have comorbid anxiety or depression or OCD, as well as how it works for people without having substance use disorder. So definitely comorbidities could be a good target to start working in the field of addiction medicine using brain stimulation technologies, as we already have those FDA approvals and insurance companies are already covering that. So that is what I do in our kind of intervention psychiatry program, because in our program we have some of the giants of the field in the program, so they are doing the people with depression, but most of the clinicians in our clinic, they really do not like to touch people with addiction, right? So they say, oh, these are the complex cases, so we usually do not do the TMS for people with addiction. But that is the specific niche that I really like. So I really like to work with that specific group of people. And it works reasonably well. So that is definitely a good option. There are specific clinical considerations. There is a new publication in the American Journal of Psychiatry in terms of how to manage concurrent depression, OCD, psychotic disorder in people with substance use disorder, and how to use TMS for them specifically. I really like some components of this protocol, but there are pieces that are not realistic. So, for example, they say, okay, if somebody is drinking alcohol, ask them not to drink alcohol for a week and then start with the stimulation. And you say, are you really seeing patients with alcohol use disorder in your clinical practice? It's not realistic, right? So you cannot just ask people to stop doing that and come back for the treatment. If it was the case, then, why we are here to just, So there are definitely some non-realistic aspect of the protocol. So we wrote a response letter to that specific paper, and hopefully the response letter is going to be published. So we discussed that, that protocol should be optimized. But they did a nice job in terms of discussing about some clinical consideration. But that is definitely a good starting point. So I think that specifically for the field of addiction medicine, for targeting the comorbid part, it is actually the prime time. So we can use neuromodulation, specifically TMS, for comorbid depression in people with substance use disorder, and there are definitely great clinical potentials, and insurance companies are covering that, at least in the US. So there are definitely potentials on that side. However, and interestingly, the protocol that we are using for depression is left DLPFC. So it is the same protocol that we are discussing for that could potentially be helpful for craving as well. So there are definitely rooms for using that in the actual clinical practice. And I think that I'm not making a specific recommendation, but it's just considering that in the future that could be a potential starting point, and then seeing how that is also helping their substance use and other issues. The last point, those who have been here on the Innovation Day, we had Anton from a group of people who kind of the society that they have for people with lived and living experience of substance use disorder. He made a comment about our presentation. Do you remember what was the comment? He said that your slides about brain stimulation is scary to me. Because talking about brain stimulation, people have a background in terms of just, it could be, it's important how you communicate that with your patient, how you communicate about brain and recovery with your patients. And that is an issue that we have been addressing, and we are working on that. So trying to develop a specific level of understanding about how addiction is impacting your brain, how addiction when your addiction is in the recovery process, how your brain should be recovered, what are the specific exercises that you can do, and giving people an understanding, a neuroscience-informed understanding about their brain and recovery, and then how neuromodulation could be helpful in this process. So this is a specific area that we are investing on, and we are developing new materials. The good thing is we already have them in 22 different languages. So we presented them in ISAM meetings a few years ago, and then many colleagues from around the world, they came and said, okay, we want to translate them into our languages. And now we have them in 22 different languages. And you are definitely welcome to translate into other languages. We are happy to support them. And all those languages are already available free of charge in this website. And now we are developing new versions specifically for neuromodulation. Hopefully, we will be able to provide them. Specifically in Minnesota, we are developing a network of neuroscientists and people who are in recovery and in recovery communities, trying to work together for innovation from the starting point, and having them engaged in this innovative process and have them as a part of the process. Take home notes. You can have my slides in the QR code. Today we discuss about circuit-based therapeutics for addiction medicine, and that is an area for collaboration, education, joint research projects, and this is the reason that we are here. Colleagues from China, colleagues from India, colleagues from other parts of the world, how we can do things together. We discuss about targets, we discuss about dual target model, we discuss about the dose of the stimulation, we discuss about context, state, we discuss about the timing of the stimulation, the reliability of the targets, we discuss about comorbidities and the importance of comorbidities, and a neuroscience framework, because at the end of the day, it's not only neuromodulation. We also provide them with therapy. We also provide them with medications. How these interventions could work together in the same neuroscience framework, because we know how these medications are actually working on these circuits, how these therapy interventions are actually working in these neurocircuits, how we can have a unified neuroscience-informed framework that could inform all those interventions that we are doing in a same space, and how we can engage them together as a holistic way of seeing addiction treatment. Discuss about importance of neuroscience-informed psychoeducation for patients, and also global collaboration. One few last slides. If you look into the publications in the field of neuromodulation for addiction medicine, only 22% of them are coming from the US. Almost the same amount are coming from China. And I was checking that just a few days ago, and it seemed that China is a little bit higher than the US as well. I mean, China is just going ahead of us. And then other countries, Italy, Iran, Brazil, Germany. So there are other countries that are collaborating together. So we realized that we need to have a network of labs working together. So we developed what we call INTOM network to collaborate together. So we have publications discussing about how to do this collaboration international level, and we already have 55 labs around the world that are working together to promote these international collaborations. We have a YouTube channel. Every 2 years, we get together in New York and discuss about how to promote the field. The next one is going to be in 2026. We had the last one in 2024. We have different consortiums, different technologies working together. And specifically within International Society for Addiction Medicine, there are specific potentials for this collaboration. So in the first day of conference, we had 1 day discussing about innovations, and you are definitely welcome to be a part of that collaborative network. And thank you very much for your attention.